want to thank everyone for being here for our presentation for you tonight on how digital occlusion can impact your practice. My name is Shane Varga. I cover the western half of North America for Tscan. So I'm excited that everyone is able to be here and be part of this presentation. Just a couple of quick things here. I believe it's on the bottom for most people. There's an area, so this video is being recorded. So if you want to watch it again after you've watched today, you'll get a recording of it. At the bottom, there's a place called Q&A and chat. So in chat, I'm going to put my information if anybody wants to contact me directly. I'll give you my email and my cell phone number. In the Q&A section is where you want to type your questions. I know Dr. Stevenson is going to be moderating that. So he may answer some questions. He may ask some questions directly either during the presentation or when it's all said and done. So put all your questions down in the Q&A section. If you have questions for me, you can always put it in chat as well too. So again, I also want to say Stevenson Dental Solutions, thank them for sponsoring this event here. I know Dr. Stevenson wants to say a few things, so I'm actually going to bring it back to you, Dr. Stevenson, to let you talk a little bit about what you want to talk about as well too.
And after I talk, we can let Dr. Kerstein start, right?
Correct.
Great. Okay, well, hi, everybody. I'm Rich Stevenson, and I'm not going to give you my bio. I think most of you probably know me through either taking a course from us here at our center or perhaps on YouTube or Instagram or something like that. You are part of my bigger family of clinicians. It's great to have all of you here with us tonight from all over the world. And it's really cool that we can do this. I'm just really excited today because you're being treated to one of the best clinicians we have in our profession. Robert Kerstein he is an amazing man, a very nice guy. And I had the pleasure of spending several hours with him when he came to give me some advanced training on this technology that we want to share with you, which I am wholeheartedly an enormous fan of. But let me tell you a little bit about, you know me, let me tell you a little bit about Dr. Robert Kerstein. I saw him present many years ago at a meeting in Chicago, and I didn't know him at the time, but I thought, this guy has got the most amazing message to tell. Everyone should be all over this. And at that point, I dedicated myself to eventually delving into digital occlusal technology. So let me tell you a little bit about Dr. Kerstein. He is a DMD, and he got his degree in 1983. And then he went on to get his prosthodontic certificate in 1985. And both of those were from Tufts University School of Medicine, where most of you know is in Boston, Massachusetts. And then from 85 to 98, he maintained an active appointment at the Tufts the School of Dental Medicine as a clinical professor teaching in fixed and removable prosthodontics. In 1984, he began studying the original Tscan 1 technology, and since that time has also studied Tscan 2, Tscan 3, Tscan 7, 8, 9, and now the present day version, which is Tscan 10 technology. And I have Robert, I watched Tscan 2 at the beginning, and I watched it evolve over the years, and I jumped in rather late. I wish I had jumped in a lot earlier. But over the last 39 years, Dr. Kerstein has published over 100 original clinical papers and research studies using all versions of the Tscan. That led to his becoming the leading authority and researcher in the field of computerized occlusal analysis. His findings have been published in, here's a list of the journals. You guys will be blown away. The Journal of Prosthetic Dentistry, the Journal of Craniomandibular and Sleep Practice, Quintessence International, Practical Periodontics and Aesthetic Dentistry, a Journal of Computerized Dentistry, Compendium of Continuing Education, the Journal of Implant and Advanced Clinical Dentistry, Cosmetic Dentistry, Advanced Technologies and Techniques, and the Journal of Oral and Maxillofacial Implants. Holy moly, I am absolutely in awe. That's incredible. Additionally, Dr. Kerstein has edited a 3-volume research handbook about all the known applications of Tscan computerized occlusal analysis technology. He is clearly a pioneer in this area. He's an advocate for digital occlusal technology. And I think, I can totally attest to this. I'm kind of reading his bio, but I'm ad-libbing, I'm sorry. He teaches a measured system which greatly improves success of bite-related procedures, commonplace in every dental practice. I can tell you that is absolutely 100% true. While he was mentoring me at Stevenson Dental Solutions, I was doing occlusal equilibrations with his guidance, and that is deep learning, man. It's incredible. Thank you for that, Bob. Anyway, his digital measured occlusion provides predictable rapid bite comfort for most patients while lessening prosthesis breakage and remakes and shortening treatment times. Hello. If that's not important, I don't know what is. And I'm just delighted to be here with Bob and with Shane and with a great company that makes an amazing product. And let's find out more about it. So with that, Bob, it's all yours. Take us in there.
Well, thank you for that very nice introduction, Richard. It was my pleasure and Shane's pleasure as well. The two of us were together when we indoctrinated you into how to use the Tscan to help make intelligent decisions about what to adjust. And that's really the essence of what the Tscan does. Is it takes a lot of the guesswork out of how you would make adjustments to a variety of things. So I'm going to give your group an overview of the technology and discuss aspects of it, and also some aspects about the articulating paper and scanning technology in general, to give everyone sort of an overview of where we are in occlusion, in the current status. And I'm really excited for the opportunity to share with your students. I know you have a very fine educational continuum, and they're very fortunate to be learning from you, and I'm grateful for the opportunity. So I'm going to give you an introduction to the Tscan 10, and as Richard pointed out, I am a prosthodontist, and my educational focus has always been digital occlusion education, which began back in the 1980s. Let's see if yes, and I want to thank Dr. Stevenson for hosting this presentation. He may have seen it many years ago, but he did actually take those steps to get involved, and it's really very rewarding. And I'm grateful for his interest, and I'm grateful that he's given us a chance to share this information with all of you. So he read about my bio, so I don't have to really go through too much. I would say to you that I am a consultant for Tscan, the corporation who makes the Tscan. You can see me here using the Tscan on a patient, which I'll go into a little more detail. I am a consultant for Tscan. I do not receive compensation for sales of any Tscan products, and the opinions expressed today are mine and not those of Tscan, the company. Dr. Stevenson alluded to the fact that I've edited a 3-volume handbook. This is the most recent version, published in 2020. This version, the 2-volume, was published in 2015. These contain, as he pointed out in the bio, that all the applications we know about the Tscan, which has been extensively researched, and you may not be aware of that. So there are applications in implants, there are applications in orthodontics, there are applications in general occlusal diagnosis, there are applications in prosthodontics, there are applications in posture, and there are applications in TMD. And so there are ways to use the Tscan in almost every discipline in dentistry. But the basic use is really to help guide you in choosing the right contacts to adjust, whether that be on a partial denture, whether that be on an implant crown, whether that be on a natural tooth occlusal adjustment. So, and you'll get a feel for that in this presentation. What the Tscan 10 really allows you to do is to gather real-time dynamic occlusal force and timing data from between the teeth So you can see the patient here is biting on this sensor, about to bite on this sensor. And that aids you in installing dentistry, as well as diagnosing a patient's occlusion. And I'll show you some examples of both. And you can see the patient bites down, and then, data comes out on the screen. And I'll actually give you a little overview of what you're seeing here. But the data capture is instantaneous, and it happens as you are gathering the information from the patient. So there's immediate data that comes back. Some of the software features that we'll talk about today, this is called the center of force. When it travels down the middle like this, if you watch it again, I'll just show you the video. You'll see as the data is being gathered, the center of force comes down the middle. It shows very good balance. There's also software features like the right side and left side balance here. This is a very balanced bite. And you have force percentage per tooth. And you have a force versus time graph, which looks complicated, but it's actually pretty simple. The black line is total force. And here the patient bites down to full contact. This is where they're in MIP. Here's where they open. The green line is the left half of the arch, and the red line is the right half of the arch. And that's important that you have some background, because you will see a fair amount of Tscan data in this presentation. So what is the Tscan? So first, this is the Novus recording handle, which houses the Tscan sensor, which is a sophisticated electronic circuit that is scanned 3,000 times a second. And what happens is when the patient bites on the sensor, the surface is compressed, the top and bottom surfaces are compressed, and the degree of compression displaces electricity that's in the sensor. The greater the applied pressure, the higher is the displacement. The higher the displacement, the more is the applied load. And what happens is the handle then captures all this information and scans the data as it's being streamed through the sensor to the handle. And then it's produced on your desktop in 2 and 3 dimensions. The 2-dimensional map looks a lot like a dental arch. It is a dental arch, and this is a very important software feature. The 3-dimensional arch gives you the intensity in heights. And so here you might see, like, this purple is a very high force contact. That corresponds to this palatal cusp of tooth number 14. So these two data sets are the same. This view really lets you see the unevenness of the bite. For example, high force, moderately low force, moderate force, medium force. Low force is very blue and dark, high force is pink and red. And so you get to be able to grade the different contacts, and it plays as a movie, which you're going to see. It's not a static image. And that movie matters. The timing really matters. And a lot of the corrective things that you make are time-based, and you'll see some examples of that as well. So there are many uses of the Tscan, and I'm not a big list guy, but I will show you a few lists. And these are everyday practice uses. One of the most important ones is to make an initial patient exam, an occlusal exam. Within 4 movies, you can learn a tremendous amount about someone's bite, and I'm going to illustrate that to you, which is something that is a very important aspect of it. But typically, we talk more about treating occlusal problems like isolating a tooth that hurts. That's very predictable with the Tscan, treating after orthodontics and optimizing the outcome, installing dental prostheses and implant prostheses, which I'll show you a number of examples of. This is a very interesting one. With specific ways you use the Tscan, you actually can treat cold tooth sensitivity right in the chair. And I'm going to show you an example of that. Instantaneous reduction in cold sensitivity by controlling the loading on teeth and the timing on teeth. This is a very important application. We have developed treatment for TMD that involves no splints, no night guards, and it's definitive treatment. It's been researched since the late 1980s, and we have the most papers about this treatment. The most papers about Tscan involve this treatment, and the treatment is being used all over the world. It's called exclusion time reduction, and it bypasses the need for splints and deprogrammers and TENS and orthotics and any kind of appliance in a applicable patient. And the thing about that is there are many, many applicable patients that you see, and I'll show you not the treatment, but I'll show you an example of the type of patient that really responds well to exclusion time reduction therapy. Any kind of natural tooth occlusal adjusting, I mean, just knowing how much force is on each tooth, where it's intense, And where it's moderately intense, where it's low force, makes a huge difference in your ability to be able to choose wisely what to adjust. And essentially what you do is you mark the teeth, but the data guides the contact. So if I was going to correct this pink contact, I'd be looking for the paper mark that was in the distal fossa of tooth number 15. And although that sounds simplistic, the paper mark may not necessarily be big. It may be very small and inconsequential in terms of what we think of as being forceful. And one of the things we've discovered, which I'm going to share with you, is how really difficult it is for you to choose paper marks by how they look and obtain good occlusal outcomes. It's actually the reason why people have difficulty like putting in a new case. The person comes back 4 or 5 times. That's because we're choosing paper marks that actually don't measure anything occlusal, despite what you may have been taught. So that part of the program might be very eye-opening to you and also challenging to you. But this is an example of how powerful the Tscan is. This girl is being treated. She's about to be treated, but before she's going to be treated, she's going to drink ice water, and you're going to see it on her face how difficult it is for her to drink ice water. And then she's going to have her bite adjusted with the Tscan, and in the same appointment, she's going to drink new ice water, and you'll see a very big change because cold tooth hypersensitivity is actually an occlusal problem. It's not an exposed dentin problem. It's not an exposed root problem. It's a problem with how the teeth are struck. So here's the preliminary situation. The other thing I want to tell you is one of the nice things you can do with the Tscan is work with EMG. I'm not going to talk about the EMG, but what I want you to understand is all the things you're going to see are driven by the Tscan. The EMG is very powerful technology, but it's not a treatment technology. It's a monitoring technology. Only the Tscan is the treatment technology. So this is before treatment.
Take a mouthful of water, not just a little sip. Good. Swish, 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 swish. Okay, swallow.
You can see it in her eyes.
So rate that on a pain scale from 1 to 10, 10 being the worst, 1 being it's just cold.
It's probably a 7 or 8.
Okay,
It's pretty cold.
okay, all right, good.
Switching wasn't easy.
You could certainly see it in her eyes. Now she's going to go through having her bite
Take a
adjusted.
mouthful of water.
That's the same video. Wait, let me get to the next one. There we go. Okay, now this is after, right? This is after, same appointment, 45 minutes later.
Swish, 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 swish. Swallow. Where would you put that on a 1 to 10 scale?
Like cold. Pain, like 2, 1.
Okay.
45 minutes. Tscan guided occlusal adjusting. High precision, high tolerance, guided by numerical metrics. Makes a huge difference to the occlusal neurophysiology. And she was drinking ice water. That's a fresh glass of ice water. That's not the same one from 45 minutes ago. And so we have actually published studies, 3 separate studies on treating cold hypersensitivity with the Tscan, and the results are, it's basically controllable by occlusal adjustments, but it's high precision occlusal adjustment. Okay.
Hey, Robert, not to interrupt you.
Yes,
but
okay.
Do you see that gray or blackish bar at the top of your screen?
I see the toolbar for the
There's something covering
Yeah.
the top of your slide.
Yeah, I think you can move the toolbars. You can pull it down to the bottom.
let's see if I can drag it down. I don't know if that's blocking the bottom now.
No, it's still at the top.
Yeah, on my screen, it's at the bottom.
Oh, there you go. Now it's at
There
the
we go.
bottom.
Okay, so it might block some things at the bottom, but we'll see. I've tried in the past to actually get it off the screen, but sometimes it doesn't. Let me see if it gives me an option to hide the toolbar. I'm just curious. No, it doesn't. Show video panel. No, it doesn't. Okay. So as I said in my list of things, I'm not a big list guy. The Tscan is a very powerful occlusal diagnostic tool. And, like we look at someone's occlusion, we have ways to diagnose them, right? We make models. These days we might scan, we articulate casts, we study their movements with virtual articulation. But what's missing is what's going on between the teeth. And this is what the Tscan sensor gathers. So here's an example of using it as a diagnostic tool. So here's a typical patient. If we look at her occlusion, what can we see? Well, we can see there's some recession, right? We can see that she has abfraction in some of the teeth. She's class 1 post-orthodontic. She looks like she has canine guidance, both sides, although she's worn her guidance late in the guidance, at least on this side. But we don't know anything about what's going on between her teeth. Like, for example, what's the right to left balance? Can we tell from this picture? Absolutely not. Which teeth are hitting earliest? Which teeth are taking the most force? And typically we would ask the patient, like, well, where's it feel high? And that we would think was their first contact. But that's not true either. What the patient feels has actually been studied, and their ability to tell you about the occlusion is actually marginal. If something is grossly unpleasant, they can tell you, like a new crown being high is not hard for them to tell you. But what about all the intricacies of their bite can you see? Okay. And for example, here's a protrusive movement. You know, we show you these pictures and we say, oh, she discludes, but no, that's not necessarily true, because this is the end of the movement. And this looks like she has canine guidance, class 1 molars, you know, all these things we say, but what do they really mean? And what's really going on between the teeth? None of that can you tell. And you can't even tell that when you do virtual articulation or you scan, because scanning is done with the teeth apart, right? This is one of the great misnomers today. Scanning companies are suggesting the occlusion in their occlusograms. How does someone get scanned? Their teeth are apart. So how can the scanning companies tell you about the forces or the timing or the balance? They can't in any way. And hand articulating casts on an articulator and marking with carbon paper doesn't tell you any of that information either. But the Tscan sensor does. Okay, so just to give you a little history, this girl is a clencher and a grinder. She's had long-standing facial tension. She has mild recession, as you saw, and some mild occlusal erosion, but basically she's occlusally sound if you look at her, and her condyles are very healthy, yet she has ongoing now 20 plus years TMJ pain that came on not right at the end of ortho, but as an orthodontic young adult. So I'm going to show you her recordings, and then I'm going to go into the Tscan and show you her data. So you're going to get to see how we record. Let's see if I
You're
can
gonna
do
watch
this.
me exaggerate that, because I'm gonna record you biting down twice, okay? So I'm gonna come from behind, which I typically do. I make sure the sensor's on her teeth. I float the sensor. I look at the screen.
You can see the data right here.
Bite down for me, squeeze hard, good, and open, and bite down again, squeeze hard, and open, good. Yeah, you don't have to kill yourself.
Okay, so I'm going to leave this, and I'm going to share my Tscan. I'm going to see if I can go directly to my Tscan. Yes, I can. Okay. Can you see the Tscan now, everyone?
Yes.
Okay, good. Thank you for telling me that, Richard. So this is her dental arch set up to match her, which is something that you have to do. It's not this is the standard Tscan generic arch. You'll see some examples in the presentation about using a digital scan, which works very well. But this is her bite. She's about to make, she made 2 bites or 3 bites. So I'm going to show you one of her bites. I'm going to actually have to put the toolbar up top so I can use the Tscan. Okay. And she's at the beginning of the first bite. So she bit down, she held her teeth together, and she opened. And now you're going to see that. And what you're going to see is the evolution of pressure across time. So she's actually loading her right posterior teeth a little with moderate force, but her left posterior teeth are actually building up pretty moderate force. Then there's a change and some static, right? And difficulty actually fitting her teeth together. In the second bite, let's see what the second bite looks like. And you see the same earliness and the same static occurring in the same place, right? Which means there's friction there during closure. The teeth don't fit together very well. And watch that again. You'll see it happen now. See that subtle, sudden jump in her forces? Those are things you could never see because they last thousandths of a second, right? And so there's a real problem here on 15 mesial fossa, 15 distal fossa, but there's also a problem on 3 mesial fossa, mesial palatal cusp, and distal fossa. And then there's low force throughout. And this is actually the way an orthodontic patient looks, not the friction, but the inability to have significant forces anteriorly. This is how an orthodontic patient looks. extreme posterior force, very little anterior force. So if I record on someone and they give me this profile, I immediately know they had braces, right? And look at the center of force. It shows you that the right side is early in the bite, first rising, there it is, then the left side is late, and you see it travel across the screen. And the balance that she has is 58 to 42. Now, when you looked at her MIP picture, there's no way you would know that she was 58 to 42. She could have been 65 to 35, right? So this is an orthodontic profile, extreme posterior force, very little anterior force. So that was her closure. So let's go back to the PowerPoint. Let's see if I can share that without, so you can see me. Here we are, PowerPoint, there we go. And everything's optimized. I'm going to show you the next slide.
You're gonna watch me.
Which is when she can make a right excursion. So one of the beautiful things about the Tscan is you can record closure, you can record excursive function, you can record clenching and grinding on the sensor, you can record chewing on the sensor. There's all kinds of things you can record. This one you can see a little bit better because the camera was changed. We reoriented the camera for the group. And now she's going to bite down and slide to the right, I believe, and you'll see that happen.
Blank recording screen before you go into the mouth. Okay. Same thing, same position. I'm going to make sure it's on the front teeth. I'm going to look at the screen, hit the button, bite down for me, squeeze hard, go all the way, now go to the right. Keep going, keep going, keep going, keep going, and good, you can open. So she has premolar guidance.
Okay, so I could tell from watching the screen what she really had by watching the recording. And that's a skill that you need to develop as a Tscan user, as you watch the screen and make sure the patient does what you want them to do. So this movie, here's the force versus time graph. She bites down, she has that friction again, and she squeezes the full contact. And then here she goes to the right. So the closure part is very much the same, which is very true. You see the same places, you see the friction. It's amazing how repetitive the data is, okay? And again, you see the center of force is hugging the left side, 57 to 43. So a slightly different balance. And then she holds her teeth together while during the time that I'm watching the movie, then I'm going to say slide to the right. So that occurs here. And one of the features, it's a little complicated to read this, so I'm just going to help you. Here's where she slides to the right. And one of the most very important things we can do with the Tscan is we can separate the anterior guidance from the posterior teeth. We do that with this quadrant division. And she went to the right, so we're going to separate 6 from 5. So 6 is the red quadrant, and 5 and everything back is the blue quadrant. And what you can see is that she has an ongoing blue quadrant in this excursion. The orange quadrant, which is the posterior left, it is also involved in the excursion. And then she also has these steps, which are friction as she moves across her teeth. And again, these things are happening in thousandths of a second. The anterior guidance quadrant is the red quadrant, and you can see it doesn't really work, even though the picture we saw said she has canine guidance. And this is what I mean about seeing the truth of the occlusion. There's the balancing side blocking her. Now she's moving into a posterior group function. The right side is engaging posteriorly. This tooth is not disengaging. And you can see the blue line is active and the yellow line is active and the red line is not really taking control. Now, as she gets further to the right, the premolar takes over. And if you remember, I said in the video, she has premolar guidance because I saw this happen. Group function, balancing contact. Now the balancing contact is going to disappear right here and you'll see it go away. And she maintains the group function and she shares that with the canine and the premolar and a little bit of the lateral. And you see the columns sort of go up and down because of the friction. Like watch the columns sort of go up and down. That's friction. See, they go up and then they go down and they jump. That's stuff you could never see with your eye, right? And so making an intelligent diagnosis is incredibly simplified by having live data from between the teeth. So that's her right excursion. And I won't show you the recording of the left one. I'll just show you the data. Here she bites down. You see the friction again. As that jumping, you're going to see the columns jump. Here's where she goes to the left. And again, both the orange quadrant and the blue quadrant are active. And yet in the picture, she looked like she had canine guidance, right? That's the misnomer of looking at the teeth, right? Looking doesn't show you what the T-scan measures from between the teeth. There's some friction. She's trying to go left, but she can't really go left because the right is in the way and the left is in the way. And you see that here. And then the columns are jumping again because of the friction, which the black line shows you, right? And all of this detail is captured by just making a good recording, right? And so these are the information that's hidden in the occlusion that you can only capture dynamically by having a high precision sensor between the teeth, right? And ultimately she does reach her anterior guidance, but it takes her a long time. You see the green line finally takes control, although she maintains posterior right and posterior left contact for a very long period of time. So this is the kind of power that the T-scan offers you. Okay, let me go back to where I was. Okay.
Want a blank?
Okay, so after all of that, why do you, the clinician, need the T-scan, right? Supposedly the carbon paper is adequate, but why do you really need the T-scan? Well, there are many patient benefits that you may not be aware of. If you were, you probably would have gotten involved with the T-scan. One of the most significant one is that there's immediate patient positive occlusal feel, and it happens right in the visit, which makes it easy for patients to accept new restorations, especially large ones. It makes it easy to rapidly case finish, meaning you don't need 5, 6, 7 appointments. You can do it in one appointment and one follow-up, which is what I did for many years as a prosthodontist. And patients are really impressed with the T-scan. But this is a typical patient who just had her bite adjusted with the T-scan.
Okay, Rosemary, you just had your bite adjusted with the T-scan. So how did it change? What's different for you?
I cannot believe how drastic the change is. It feels so much more comfortable, and I'm just blown away by the difference and the progression as we went through the process and used the machine and just pinpointed different spots. It was just amazing. It's just amazing science. And
So what she was saying was we used the technology to pinpoint the problem contacts in her mouth, whether that be closure or excursions, and she lived through it. In other words, we would record, and Richard also experienced this, and we would read the data, and the data would say mesial of 3 is a problem, distal of 7 is a problem, 15 is too long in an excursion, whatever the findings were, like I just showed you. Then we would guide the adjustments, and then we would make a new recording and pinpoint new areas that were problematic until we had it all moderated. And you'll get to see what that means when I show you some case examples. But immediately she can tell how much less pressure is in her face, how much more comfortable it is to bite down. It's not, it's a typical routine outcome for someone. This is not because I have a video of this one person. There are videos all over YouTube with people saying these same things. So the power of the T-scan is it isolates the true problem contacts for you and then allows you to quickly improve the outcome. And that's something that you learn by learning how to use it, basically.
Okay.
Right. But I told you I wasn't a list person, but I'm going to just give you a couple of lists so you can understand how many things we've studied with the T-scan and what the benefits are to the patient. Well, this is the benefit to you, actually, knowing that you took someone who was 65-35 and made them 50-50, right? And I often ask this question when I lecture in a group: if you knew your denture was 75 left, 25 right, would you send the patient home? And nobody says yes, but nobody really knows whether that's true or not, because you can't measure right to left imbalance in carbon paper, right? But if you control the outcomes with measurable improvements, you have less postoperative bite adjustment visits. It's one of the greatest advantages. And I'll show you some examples of people that came to me after many bite adjustment visits where they were able to resolve, I was able to resolve them in one visit. This is a huge one in today's digital workflow, reducing implant overload and all the things that go on with that, which is part breakage and screw loosening, porcelain chipping, which is the #1 most frequent implant failure. This is a huge one also. Finishing your orthodontic cases with the T-scan minimizes the development of post-ortho TMD. And I just showed you an example of treating cold sensitivity. We didn't cover her roots. We didn't give her desensitizers of fluoride. We treated her occlusion with high precision occlusal metrics, right? This is, as I mentioned earlier, treating muscular TMD without deprogrammers, NTIs, appliances, TENS, orthotics, Botox, PT, chiropractic. All of these things don't treat the cause. They get in the way of the teeth. They interfere with the neurophysiology by blocking the teeth from striking badly. But TMD, muscular TMD, is a bite problem. We've been treating it for years and publishing about it for years, that without making any appliances and resolving it in 60 to 90 days. We have many, many, many studies that you just may not have been exposed to. We've also shown we can improve chewing dynamics, speed, chewing width, strength, cycle time, speeding up cycle times. And this is in TMJ groups, that they can improve their chewing within 7 days, actually, after having their bite adjusted with the Tscan. This is a really important one. You can often reduce Piper classifications 2 levels by treating the occlusion. As long as there's a disc in there between the condyle and the skull base, the patient is safe to adjust their bite. And when we do that, we often find that the disc pathology lessens by up to 2 classifications. So if you're a Piper 4, which is almost a fully displaced disc, but there's still a disc in there, after treatment, you're usually around Piper 2, which is the beginnings of disc displacement. So taking pressure off the lateral pterygoid allows the disc to recenter itself. And again, there's nothing done to do that with an appliance or with physical therapy. It's all done occlusally. This is a very important thing. People who live in chronic pain get emotionally depressed. And we've have actually multiple studies now, at least 5, using depression indices, like real psychometric tests that are used for people that have depression, that after we fix their TMD in this way and get rid of their chronic pain, their emotional depression goes away. So if anyone is telling you that TMD is an emotional problem brought on by stress in your life, it's completely incorrect. It's an occlusal problem that brings about chronic pain that leads to emotional depression. This is another huge area. We have published papers now for many years treating headaches and migraine. And we reduce bruxism. Clenching and bruxism is mostly a tooth problem. There is a psychological component, but people who have their bite adjusted specifically in specific ways with the Tscan, they stop clenching and grinding, or they dramatically reduce clenching and grinding within 7 to 21 days. And that's, again, without wearing anything, no external therapy. And this is a new area that we're beginning to explore, that we found that posture, metrics like sway and forward head posture and uneven shoulders and bad center of gravity, when you treat the bite to high precision metrics, you often have the posture improve, right? So these are all the, sorry about that, I keep clicking. These are all the things that are available to your patients and to your practice if you're interested in getting involved with the Tscan. That these are all things that we've researched. Now, this is not me saying this just to say it. We have studies on all of these things and have for many years now. So all of these benefits, right, are in published research studies that, as I said, you may not have been exposed to because of who you studied occlusion with. If they didn't introduce you to it, you wouldn't have known about this. And that's one of the great things about Dr. Stevenson. He's introducing you to it. And the reason we get these kinds of outcomes is because we can measure thousands of seconds of incremental data from between the teeth. And you saw it in that one patient. I showed you their diagnosis, how there was friction, how there was uneven closure forces, how there was an imbalance, how they didn't exclude well. All of those things you can only gather from between functioning teeth. You can't get them from scanners. Scanners take pictures of teeth that don't touch, right? So that's a very different technology. Only with a high precision digital sensor between the teeth can you capture all that information. So systematic reviews are, the new thing. Everybody writes systematic reviews and they hone in on specific focus questions. This one looked at occlusal indicators, static, meaning wax, silicone, carbon paper, stone models, versus quantifiable occlusal indicators, which is essentially Tscan. And most of what we do is try to interpret this, all of us, on a daily basis. And interestingly enough, there are only 20 papers in the literature that talk about carbon paper as an occlusal indicator. And all of them show it doesn't measure anything. Yet we use it as if it does. And we use it in the way, well, we think that's a lot of force because there's a lot of ink. And we think that's, light force because it didn't mark well. Actually, none of that is true. And I'm going to show that to you. So little evidence supports the use of static occlusal indicators in the way we use them without a qualifier. In other words, just looking and choosing, it's not very reliable. And you may have experienced that, where one case you put in goes really well, and then you do the same thing on the next case, and the patient comes back 5 times, and you don't really understand what the difference is. The difference is none of these marks really mean anything other than one thing: surface area. That's all that the ink is showing you. It's not showing you force, pressure, and timing. This is not simultaneous, right? And only if you measure between the teeth with something that can actually capture pressure can you know that. Alternatively, the Tscan has much scientific evidence. There are over 400 papers in the literature, 20 papers versus 400, right? Tscan measures relative occlusal forces and timing objectively, accurately, and repeatedly, right? That's what you need to be effective at the chair, right? So here's the thing. If you want all those benefits for your patients and your practice, you certainly do need a Tscan, but there's something even more basic to getting all these benefits. You have to choose the right contacts to treat. And dentists don't choose the right contacts to treat. For example, in this picture, what would you treat? If the patient said, well, my lower right side hurts ever since you did that filling on my upper first molar, right? We'd go in and mark and we'd choose. Well, what the Tscan does is it shows you which contacts to treat and which ones to leave alone. And then you choose intelligently. And here you see the highest force is the smallest mark, right? And here's a big mark that's moderate force. And here's a big mark that's low force, right? The challenge for you is to know what these mean so that you choose them wisely, right? And this is a perfect example of how misleading the paper marks are. 3 large marks. Now look at the tooth structure under those 3 large marks. It's perfect, right? There's no damage, there's no cracks, there's no nothing, right? But here, where there's no paper, there's exposed dentin. And then if you look at the bottom tooth, the counterpart, there's exposed dentin, there's no paper. The paper is actually pushed to the periphery. The ink is outside the exposed dentin. And of course, all of us have had trouble marking exposed dentin, right? And the reason we think it's difficult to mark is, with smooth tooth structure, or, we come up with all these reasons, but there's actually a very important reason why you don't see much ink on exposed dentin. And then here are the counterpart 3 lower marks. Now look at the tooth structure. It's perfect, right? Now look at the real data, right? Tooth number 2 and 31 in this area, and in this area are taking 50% of the patient's bite force, right? And so if you look at this area, it's low force. So these marks, see these 3, right? That's how misleading the paper marks are, right? And the reason there's no ink on exposed dentin is because there's too much pressure. If the enamel can't survive, how can a piece of paper with ink smeared on it survive, right? We don't think about it that way, right? We think this is forceful, right? Look where the enamel is gone, right? That's where all the pressure is. So ink and paper is not going to be able to tell you these important things, right? Here's another problem with the ink. We're taught we should make all the ink marks the same. Whoops, I'm sorry. We're taught we should make all the ink marks the same. That means we've equalized the forces. Completely untrue. What you've done is equalize the surface area. They're all the same size. That's not the same load. Here's an example of that. Here's 3 crowns being put in and someone's bite being adjusted, and you see all the marks are being made the same size, right? Well, at least these on the crowns are. But here's the information you need after you do this, after you make your basic correction to fix the bite so that it has, let's say, the correct locations of contacts instead of all these lines and interferences, right? The information you need is this information. This is what's missing, right? So the fact that I made them all the same size, this one still needs to be reduced more. This one still needs to be reduced more. And these I probably should take down a little bit also, right? Now look at the big mark on the canine, low force, right? So this is what's missing from your ability to know what to adjust, right? you can deliver the case the way you think it should be and grind in the paper marks the way you want to grind them in, but then you take the data to it and then you optimize. That's how you get really good outcomes, right? So this is a study we did and just showed that the Tscan sensor reproduces force. This is 6 different contacts being crushed 20 to 24 times, gives you very linear force reproduction. But this is how you use the information. So watch this recording. I'm going to stop it right away. See, this tooth is way too early and way too forceful. This would be the upper left central incisor. So that would be the first place I would adjust. And then I'll play forward from there. And then you see these 2 places start to rise quickly. So then I would go to this marginal ridge and to this distal fossa. And then that gets worse, right? That's right in there. And then this gets worse, which is the right central incisor. And then these 2 implants are next, right? And that's the whole bite sequence. So if you watch in continuum, you see the uneven evolution of the pressures. Well, with the Tscan, you can start and stop, fix, go on, fix, go on, fix, make a new recording, right? And this is the digital scan that I was talking to you about, the STL file. So you can scan someone and put that into the Tscan data, and then you know that this is exactly on the, the marginal ridge between the upper left second premolar and the upper left first molar, right? Or this is right in the middle of the mesial aspect of the central incisor, or this is palatal cusp, right?
Robert,
Yes,
can you go back to that image there?
sure.
Yeah, I think it's important for everyone to understand that the way you look at the Tscan, it's not like you're staring at the occlusal surface. These are from above. You know what I'm saying? Can you explain that a little bit? You're hovering from above, looking down on the mapping.
Yes.
So it's like you're seeing. You have to sort of imagine that these marks are occurring on the occlusal surface directly below that Tscan map that we
Yes.
have.
So the lower, you can actually look at both arches at the same time. You can look at the lower arch if you're delivering something on the lower arch or you want to study the lower arch. So
Right.
this is showing you the impact pressures of the lower teeth banging into the upper teeth, which is also shown on the lower teeth if you want to see it. So depending on which arch you're working on, you can choose to have one arch or both arches. And so, yes, you're looking down. This is showing you the intensities, the uneven intensities, and then you correlate that to that. And this, you can see, this map also has the tooth numbers. This is European numbers, but you can use American numbers. It just happens to be a European slide that I made. And implant warnings, that's another great feature. We didn't talk about that. If you're overloading an implant, you get a warning. And the software tells you right away, you better be careful. You've got too much force on that implant. So this is a map of the occlusal surface. This is a map sort of at an off angle, and you use them both together. So how does that play out clinically, right? So here's a really good example of how the Tscan helps you at delivery. This is an upper overdenture on implants being delivered against an existing hybrid that was made before. I think the denture was being remade. And this is our standard approach, right? What would you adjust here? And I'm not asking you to answer, I'm asking you to think about it, right? What is this good? Do you know if it's good? Can you tell if it's good? Well, there's a lot of marks and they're all distributed, right? Well, when you actually look at it with the Tscan, you find out that this area of composite is going to be under extreme load from if I didn't have the Tscan information, right? I would never know that there's extreme load here. And that's the real problem we face. So what the Tscan does is it guides the needed micro occlusion adjustments. So the macro occlusion is this. That's the macro occlusion. And what we don't really understand in dentistry, we don't really think about it, to be honest with you, is that the macro occlusion, this is the end slide of most presentations. I'm not saying this case specifically, but you get to see this picture. And the assumption is, well, the occlusion is good, everything meets. But that's the real problem, because unless you have this information, the occlusion may not be good. The micro occlusion is what matters to the patient. That's what they come back because of, or that's why something breaks, or that's why something comes loose, is because of the micro-occlusion. So, if I didn't have the T-scan and the patient said, yeah, it feels okay, I would think I had simultaneous contact and even pretty uniform loading, and I'd send the patient home, and in a few months, they'd come back with a chunk of composite in their hand. And I wouldn't know why it happened. But now I know why it would happen, right? So I can moderate this specifically using the data to guide which places in order to control this so that the composite doesn't have this extreme load on it. So that leads us into the uncomfortable part of the course, which is that there are studies that have been done that show that we doctors actually make a huge percentage, very high percentage of errors when we choose contacts, looking at the ink marks or looking at holes in silicone or looking at what we think is forceful. It's actually greater than 90% incorrect choices. And there are 3 studies that show this using over 600 dentists. And the problem with that fact is that when we choose the wrong contacts, that's where negative sequelae occur, right? So the T-scan helps you avoid this problem simply by guiding you to choose the correct contacts. So the interesting thing about this is we have all these technologies, now we have the digital era of dentistry, we have orthodontic planning, and we have scanning and milling technology, and we have CBCT, and we have virtual restorative planning and virtual articulation. Again, there's no forces in there, right? This is the macro occlusion. Keep that term in mind, right? And we have the digital workflow. And with all this planning and fabrication control and laboratory steps being, really managed in the virtual world, we have a huge number of complications. Let's see if I can put this down. We actually are having, put it on the bottom again. So I have to run a video. There's actually been shown, actually, this is not good. I'll put it back up top so you can read it. We have more complications with implants than we do with natural teeth. That fractures and dislodgements and screw loosenings and porcelain chipping is at a much higher rate with the implant case than with natural crown and bridge, for example, crown and bridge on natural teeth. The rates are staggeringly more. And of course, we say in dentistry, our solution, or well, I shouldn't say our solution is to go harder, which is like to go to zirconia. But the reason is that the systems are too rigid, right? So that just shows you how important it is to use the T-scan, right? And most of this information, these studies like this one, this 8-year study of 104 implant cases where 54% of them broke at least once, and another 26% broke a second time or more than once. Comparatively, the rates for fixed partial dentures on teeth fracture rates are 11 to 12%, not 54%, right? So the reality is the rigid systems require more precision of the occlusion. And studies like this were not done with the T-scan. They were just observational studies of how many implant things broke, right? Well, this is a huge problem for us today, right? And then there's another side of that. What happens to the patient who has a lot of dentistry done? Some of you may have run across this woman.
I had a lot of dental treatment done about 2 years ago. I had some crowns and some overlays and inlays done on all quadrants of my teeth. And after that, my bite was just completely off. And I had a lot of pain in biting, a lot of heat and cold sensitivity, particularly cold sensitivity, a lot of difficulty relaxing my teeth and jaws, even just when I was not chewing, just in a regular, holding pattern. And agonized basically for 2 years, wondering what I could do. And I happened to come across Dr. Kerstein's information on the web and knew I had to get in here. And 1 week post-treatment, I feel as though my jaw has completely relaxed and has been allowed to come forward more. I was particularly feeling a lot of sensitivity on the left side, but it feels so much better now. Cold sensitivity has started to decrease. I'm much better able to chew harder foods, things like broccoli or carrots or things that have more snap to them, nuts in particular, where before I really had to baby them and practically suck on them. Now I can actually bite on them, which is just amazing to me. So I feel there's just been a tremendous improvement.
And that's at 7 days. Cold sensitivity, right? Chewing strength. Remember I showed you that slide with all those benefits, right? She went for 2 years after having a lot of restorative dentistry done. And not until she had her bite adjusted and refined with high precision metrics was she able to get a rapid resolution. And she went to a number of dentists for help. Again, this is EMG. We use it with the Tscan many times, but the treatment is rendered by the Tscan. So the question is, why do we have all these complications despite the fact that we have all these digital advances, right? We should be having less complications because we're getting more precise and we're getting more accurate and we're getting more control over the way restorations are fabricated. Well, it has to do with this material. That's why we have complications. Understanding what this means, choosing the right places, that really matters to the patient and it matters to you, right? Here's the digital workflow. We scan and then we plan and we have all this, in-house fabrication. Everything gets done virtually. There's a lot of precision involved, not only implant placement precision, but also prosthetic precision, right? And it's all managed, with high degree of control until the last step. When we go to the mouth and we go analog, and the question becomes, what does this mean? And what should we adjust? Now, we all think, I shouldn't say that, we all feel we understand what to adjust by looking, but that's really not true because the principles that you've been taught about what to look for actually have no science behind them. So this is what you've been taught, and it's dogma, meaning dogma is believed without question, and it's dogma that you've been taught, but it's not factual, that large marks represent high force, small marks, light marks represent low force, and widespread paper mark distribution means everything happens at the same time. The reality is, when that's been studied, and it's been studied a number of times, none of it is true at all. None of it. So the reality is, we can't look at these ink spots and know what they mean. We have ideas. There are certain things we do know what they mean. For example, if this was made in an excursion, that's a group function contact, that's a balancing contact. But how much force is on this one or this one? Which one happened first, second, third, fourth, eighth, 10th? We can't know that at all. And this is what the research shows. These are the facts that we know about articulating paper. First, multiple mark sizes can represent a single load. So in other words, you can have a mark like this and a mark like this, and they can be made from the same force. That's a problem for us based on the idea that mark size tells us the load. Not at all. Then the converse of that is equally as problematic. You can have equal size marks, but they can represent many loads. And for example, this one and this one could be two very different force loads, very high and very low, very, very high and very low. You wouldn't know by looking, right? And I'm going to show you this research so you get a feel for what really what's really going on. This is an interesting study. It showed that the largest mark in a quadrant was only the most forceful contact 36% of the time. So if you always choose the biggest mark, you're going to be wrong 64% of the time. And you've actually done this without it even registering. We choose the marks. For example, let's say we deliver a crown, single crown, and the patient says it's high, and we go and we mark it, and then we grind, and the patient says it's still high, right? We didn't pick the right mark. It doesn't mean it will get adjusted in one visit, but if we pick the right mark, it would improve, right? We don't even think about that. We just go and pick another mark, right? Imagine if that was your eye, and an eye surgeon happened to miss your cornea, trying to fix your cornea, he hit your retina and damaged your retina. You'd really care about that, right? But in the tooth, we don't seem to care. We just go find another mark and keep grinding. That's a really bad standard for our profession. Nobody really grasps the enormity of that, how much indiscriminate grinding is going on. Mm-hmm. This is a master's thesis, was published in Croatia. It showed that dentists looking at paper marks will make therapeutic errors, meaning that we won't choose the right places. And the worst part of it all is all the literature suggests that you, the doctor, have to decide what this means. Subjective interpretation, that you know what that means in reality? If you put an equal sign after subjective interpretation, it means guessing, right? We guess, right? If I asked you what's the most forceful tooth, most of you won't agree. You'll pick certain marks, but you won't necessarily agree when there is only one most forceful contact. So this research will illustrate the problem for you. This group of engineers, they took articulated casts, used a vertical loading device to remove the angular forces that an articulator would provide, or a human would provide, and loaded the cast from 0 to 500 newtons every 50 newtons, and they photographed the marks every 50 newtons and then would wipe them off and reload at a higher load and photograph and wipe the marks off. They found 6 marks on each cast showed up at every load. These 6 on the top, that's why it says T, and 6 on the bottom. All the other marks, like this one, didn't show up on every photograph. So they didn't count anything that wasn't on each photograph. This is what they found. There was a trend towards increasing mark size, but if you look at it intelligently, you'll see that if you take a given load, like 300 newtons, which is average human bite force, you'll see that there are many different mark sizes, probably 20. So this is a very small mark. This is a medium-sized mark. This is a bigger mark. This is the biggest mark. But they're the same load. They're not different. They're not in the middle of the screen. 300 is median human bite force. If the mark sizes mattered, you'd have them all collected right in here, right in the middle. But notice there's small, medium, large, and largest. And any one of these ovals shows you that. Now, this one is interesting. 450 newtons actually had the biggest mark at 1700 pixels, but it also had one that's only 400 pixels and 420 pixels and 600 pixels and 800 pixels and so on. So what these ovals really mean is you can have a big mark and a small mark, and they can be made from the same force. And the challenge for us is to know that, which one is which, right? These are the same load, could be the same load. They're very different sizes, but we'll never know because there's too many sizes, right? This mark is in between. So that would be maybe that one, same load, right? That's what these ovals mean. Now on the mandibular teeth, the same. If we take 300 newtons again, you see this was the most frequently marked oval. This had like 24 different mark sizes. So you can see how challenging this would be to understand any correlation between mark size and load. But if you go horizontally and take a single mark size, right, and you see 400 pixels, every load was represented by 400 pixels. So what the horizontal oval means is you can have a lot of marks that are the same size spread out over the teeth, but they can be very different loads. One could be 450 newtons and one could be 10 newtons. You'll never know the difference by looking at the sizes. And this is a huge problem for us. This is why occlusion is complicated, because the medium we use to control the outcome is not adequate for your clinical needs or for the patient's therapeutic needs. Mark size and ink, and they have nothing to do with force, time, and pressure. And here's an example of how difficult it is to choose, right? This is a Facebook test that was done. A Facebook group, a dentist asked the question, which are the 2 highest force contacts in this group from number 1 to 9? And of course, this is what goes on in our offices. You know, we put in a new crown and the patient comes back and they say, you know, Dr. Kerstein, ever since you put in that new crown, I can't bite on that side and it doesn't feel like the teeth fit. And we have to now figure out what's wrong, right? And so the Facebook group was asked to choose the 2 highest force contacts, numbers 1 to 9. So you do it yourself. Try to do it yourself. I'll give you 10 seconds because that's all you have in the chair, right? You have to mark and you have to choose, right? Were you correct? Number 4 and number 9. I would bet you weren't correct. And that's because the Facebook group did very poorly. And most dentists do very poorly when we run these kinds of studies, right? So they chose, there were 124 dentists that participated. There were 246 total choices, 2 choices, 2 forceful contacts. The whole group only chose 12 correct choices, 95% incorrect. So the question is, what misled them? What misled them was, if you look at the numbers they chose, mostly number 1, number 5, and number 6, number 1 is moderate size contact, not really big or small, but 5 and 6 are very big marks, right? The second choice is number 8. They chose more than any other choice. 8 is a big mark. And 6, again, a big mark. Being misled by the dogma that has no science behind it, right? This is a huge problem for us because this is what goes on in our office. What does this mean, right? What are some of the questions that you cannot answer by looking at these ink marks? Something like, is this hitting too hard, right? Well, notice I picked a small mark. Why? Because small marks can be very, very forceful. Think of a lady's high heel, a stiletto heel. If she steps on your foot with a stiletto heel, it's going to hurt a lot. But if she wears a flat shoe with a big surface area, it's not going to hurt you too much, right? So many small contacts are extremely pressurized, and teeth have sharp points. They have triangular ridges. They have deep fosses. They have cuss tips. They make for very sharp points. And so you can never tell if somebody's hitting too hard because of the size of the mark. What about if there was an implant under here? When did it load? Was it early? Is it overloaded? Is it under warning? Can't tell from this picture, right? And that applies to any of these teeth if there were implants under them. Is this an area of good occlusal force? It could be. It might be. It might not be. But there's no way to know because of an ink circle with missing ink. The thinking is this is a high force contact, but there's actually no science behind that either. And here's a typical problem contact. This could be very high force, but it didn't mark well. Now you understand why. When there's a lot of pressure, the ink gets destroyed, right? But you wouldn't know without really knowing, meaning you wouldn't know unless you had a qualifier. That's what the Tscan does, it qualifies all the contacts so you understand which ones are problems and which ones should be treated, right? And which ones should be left alone. And how does that play out clinically? So here's an example that of something that I saw many times in my office. I was known for using the Tscan for many years, and people would come from all over the world to see me, to have their bite checked because they were struggling with some dentistry that was installed, or they had TMJ. But most of the time it was they had something done like a few crowns or a few fillings that threw their bite off, and they were going for now more than many visits to get help. Like the woman that you heard in the interview who had all that restorative dentistry done. She was 2 years in hoping to find help. This patient had one crown made, tooth number 13. And the day after tooth number 13 was made, tooth number 11 became painful. And it already had an abfraction, so it must have had some force on it for many years. This is like a 60-year-old male. But tooth number 11 never hurt him until tooth number 13 was installed. And the patient went back to the dentist over a series of months, many times, and couldn't get resolution. The dentist actually ended up taking out the crown, putting in a temporary crown, hoping that that would solve the problem. And this was the day the patient came to see me. He was sent to me because the story he said was, go see Dr. Kerstein. He has a bite computer. Maybe he can figure it out. So this was the paper marks that I saw on that day. But the first Tscan I took showed me exactly what was wrong. Watch tooth number 11. It rises too fast for everything else and it reaches maximal force, right? Now, why putting in the crown made that happen, I can't tell you. But this was the day he came in. And it was not difficult to diagnose what was wrong, right? So then what you do with the data is you map the data to the paper marks. Right? And you see there's a very small paper mark next to it. Further down the arch is a lot of concentrated force. And this is the premolar nearby. That actually has moderate force on it. But this was the main problem the patient was concerned about. For my own purposes, I decided to use a thicker carbon paper to see if I used a thicker paper, would I get a different mark on tooth number 11? But all I got was artifact. I didn't get a change in the contact area, because the contact was a very small, pointy shape from the lower canine that was driving like an ice pick into the back of tooth number 11. It was like a part of the lower canine was sort of sticking up and out. Now look at these paper marks, all low force, big paper marks, right? This is what fooled the dentist and would fool all of us. Paper marks, they're very misleading because they don't measure anything occlusal. Regardless of what you've been taught and what you may believe, there's just ink on paper. If you ask an engineer, can you measure bite force with carbon paper? they'll look at you like, what? It's just ink and paper. It doesn't measure anything. It's just going to smear ink around, right? But we've given it credibility that it doesn't have, right? And that's why we have struggles in occlusion. So this was the pre-op. You see the bite is very imbalanced, 62 to 38. This rise is too fast. Now watch the result on the same day, how everything rises together. And probably have to take a little bit off of this one contact, the palatal upper right first molar. But look at the balance after correcting with the Tscan. The balance is 49 to 51. 61 to 38 was the pre-op, right? And this was the post-op. And look at how the center of force hugs the middle, the balance and simultaneity is established. And the patient was really surprised that I could fix it in one visit. He goes, I've been going to my dentist for months. I don't understand it. And people like him always ask the same question of me. Why doesn't every dentist have one of these? Right? That's the question that always came up. So what does this really mean to your work, right? It means essentially that contact selection for time and force is hit or miss by looking at the marks. In even pulling on shim stock. People always say, well, I usually have shim stock to help me. Okay, so let's say you pull on shim stock on this tooth. There's 1, 2, 3, 4, 5, at least 5 contacts. How does pulling on shim stock tell you which one of these is a problem? Right? It can't. It can tell you that it holds shim stock, but that doesn't tell you which one of these 5 is the problem. You need the data to show you. So what happens is destructive forces are left in place at case insertion. Complications arise. Even if the patient says they think it feels good, it doesn't mean it is good. That just means it isn't overly noxious, right? If it's overly noxious, they'll tell you, oh, it's still high on the left. But once it gets close, they can't tell you much about it. It's much more predictable to use the data. Much more predictable to use the data. And I think this tooth is a really good example. These two are virtually the same. This one is high force, this one is low force, right? Look at the dark lateral incisor marks, both low force, right? And then look at the mesial and lingual of this first premolar. Very high force through here. Yellow is not as high as red, but pretty high force. And then anteriorly, this is moderate force. And you would never know. There's no way for you to know. And so this is your problem every day. This is our problem every day. What do the marks mean? Which one should I treat? Which one should I leave alone? Now, this is a modern day problem. I have the scanner. The scanner gives me the occlusion, right? That's the thinking. But look at it. What are you going to adjust here? What is it that you're going to adjust? Oops, sorry about that. Think about it logically. Scanners take pictures of teeth that don't touch, right? You don't scan anybody with their teeth together. You do at the end, you take a picture from the side, but nothing was gathered from between the teeth. And this is the kind of problem that the Tscan answers for you right away. So what would you adjust in this scan? You know, what is the problem contacts? Or is it all good, right? Tscan shows you right away. Just this tooth and maybe that contact. And you know exactly what to adjust. So a scanner cannot help you at insert. And these representations are very misleading. You know, the color coding, whoops, sorry again. The color coding is very misleading. For example, if you look at this contact here, it says it's red. Well, what does that mean? It's actually very low force when you measure with a force measuring device, right? How about down here? Here's a yellow one. The Tscan sees as yellow. The scanner sees it as blue, right? Well, what does blue mean? Blue means not such good contact. Well, that's not true. That's very intense contact, yellow, right? And here's a red one, which usually means good contact or tight contact. That red one is actually moderate force. That's here, right? So this is very misleading. Scanners do not capture the forces in any reliable way because the teeth are apart when you scan the person, right? So here's the question. So after registering what you just learned, you have a decision to make about paper marks and force and scanners and force. Now you have choices. You could do this. You could say, yeah, I'm doing fine with my carbon paper, and you know, the next time you need 5 or 6 appointments to finish your case, you're not going to be happy about that, right? Or you can get involved with data-driven occlusal treatment, right? And improve your outcomes, right? That's really the way to go. And as I said, I don't receive compensation for sales of any Tscan product. My goal is solely to have you be better clinicians and to provide better care to your patients. But this is the only way with data, right? Scanners and carbon paper can't do it for you. If they did, we wouldn't have all the problems we have finishing cases, right? So how do you use Tscan data to install prosthetic dentistry and implant dentistry? Well, you make a series of recordings. Let's see if I move this out of the way. You make a series of recordings and you use data to guide what you adjust. And then you re-record. Each time you adjust, you re-record. And you treat the fast rising, uneven force areas and timing areas that are too early and too forceful. And you repeat that process until you have a low force uniform outcome. And then you can look at excursions and treat excursions very effectively, actually. The excursions are a huge part of treating someone. So the first thing you do is you map the data to the contacts. This is a post-orthodontic 15-year-old who developed headaches after finishing braces, and he was sent to me after a few months after he was in retention. And this is the outcome from the ortho, 62 to 38. So I'll ask the same question to you. If you were doing Invisalign and the patient finished their case at 62% left, 38% right, would you say they were done? None of you are going to say yes, right? The problem is there's no way to know this by looking at this or by visually observing the case. I think the first patient I showed you, how much information the Tscan gave you about her friction in her bite and her imbalances, her timing, that stuff you can't get without measuring, right? So what you do is you set up the Tscan arch to match the patient, and then you use the data to guide you. So here's how you use the information. So if we just look at these three contacts right here, this is the mesial of the first molar. That's actually a big mark and it's very high force. Then if you come a little distal and slightly more buccal, you have this contact, which is moderate force. Then you go a little bit more distal and a little more lingual, and you have this contact, and that's moderate force. And then if you come to the next tooth and slightly more buccal, just a little bit more buccal, you have this contact, which is high force. And then if you come diagonally to the distal buccal, you have this contact. Now, there certainly are big marks that are forceful here, but here's the biggest mark on the side, and it's a very low force contact. So there is no way to tell by looking. And this is, again, the real problem in occlusion is knowing which contacts are problematic and which ones to leave alone. Not because they look a certain way, but what kind of pressure are they giving off? What kind of timing are they involved in, right? So here's an example of how you do this. This is a patient who had sleep apnea who was sent to me to couple his teeth. And it's such a good example, I still show it. So he was wearing this appliance, so I sectioned the appliance and then I provisionalized upper and lower teeth here. Then I sectioned the appliance here and I provisionalized this side. And then when I had the back teeth, I cut this appliance here and I kept a piece here to hold the jaw position and the vertical. And then I, prepped these teeth. And ultimately we use veneer preps and overlay crowns because we didn't have to prep that much. So these are the veneer preps. And this is the day of delivery. And you can see the gingiva is aggravated from this, removing the cement. And this is a very important slide. Let me move this down. It's a very important slide because it's an illusion slide, the macro occlusion illusion. This is a slide that you see at the end of all the presentations, right? Look at the end result we got. Occlusion looks great, right? Not till you put the Tscan in there will you know, right? This is what really happened. He was only sitting on 3 places, right? He was being held up from bringing all his teeth together. But you can't tell that from this picture, right? Because nothing's being measured between the teeth. So the process is very simple. You use the data and you map the paper marks, right? And so there's also a big timing problem here. Look at the left canine lateral region. That's in advance of the right canine region and then the right first molar area. And you only treat the problem contacts. You leave the other ink spots alone. Okay? And you go through a series of adjustments to do that. So this is all in one day. This is delivery day. This is 4 adjustments later. You can see this area is still too early, but there's more interdigitation. But the center of force, whenever it starts off to the side, like you're seeing here, it shows you the movement of the forces through the arch. This is way too early on the left side. So even though I made 3 adjustments, I still haven't fixed it yet. And that's the reality of using data, right? So you correlate the colors and the columns to the different markings, and you adjust correctly, the correct spots. This is a really important place because you see the marginal ridge has a very high force and the central fossa has really a low force. But you look at the ink marks, they're almost the same color, right? This one might be a little bigger, this might be a little smaller, but they look virtually the same, right? And yet this one almost looks the same as this one, but you would never know the extreme loading here, right? And you know, this is again the problem. Plus, you can't see the timing of the extreme earliness to this area. So we continue on. After 5 adjustments, we're starting to make progress. The center of force is starting in the middle and coming to the middle. There's better uniformity. The right side is now making definitive contact. But look how misleading the paper marks are. This is the highest force contact, and the mark is sort of like a smudge. And here's a lower force contact that's very well marked. And look at the lateral. The lateral has a dark mark, and it's a very low force contact. And here's an inconsequential mark, and it's a low to moderate force contact. So you see the data is much easier to use to figure out what you really should adjust. So a good result looks like something like this. Everything is low force. It all rises together. The center of force comes to the middle. There's good right to left balance, right? This is the nature of controlling the outcome. This took about 6 recordings to do, and knowing what to adjust. And then the interesting thing about this is if we look at the case down the road, this is 5 years later, and the case looks intact, right? But again, this is an illusion. We don't really know what's going on. This is at a recall. I used to record all the patients when they would come for hygiene recall. You can see the person's getting their teeth cleaned because I could then touch up their bite. So what did it look like 5 years later? Well, it looks almost the same, except for this area. So I can go in and adjust this contact, and this contact, and preserve the case, right? And that's what we would do. We used to do prosthodontic recall with all these complex patients, and we would preserve the case. But what this shows you is, although it's really nearly the same, if the patient goes out the door with an imbalance of 65-35, 70-30, 80-20, that's going to go to work over the next 5 years. This is how it left the office, right? Very much the same way, right? So if it goes out with a really bad outcome, you're going to see complications. The beauty of the Tscan is you can control the outcome, and then you can also manage the long term. Here's another example. This is a full mouth rehabilitation that involves some implants, metal ceramic crowns. This is a really nice case, beautiful metal ceramics, a lot of highlighting and layering of the porcelain. And this is the macro occlusion illusion. This patient came back 6 or 7 times after they got the final restorations put in. And this is why. 76-24. I ask you again, would you send the patient home if you knew it was 76-24? You wouldn't, right? And 2 implants are under overload. They were showing the lower arch here. As I said, you can show the upper or lower arch. But the reason I'm showing the lower arch is because the implants, these were opposing natural teeth, but the severe overload in this area was setting off the implant warnings, right? So that wasn't the only problem. In excursions, there was also a lot of friction from this area. And the friction you can see, this is going to the right. How do I know that? The red line's rising. So watch the friction. You'll see the chopping of the columns, right? And the friction was worse going to the left. See the friction? Much worse. Watch the columns, right? And all of that happens. That frictional period, this is about 4.5 seconds. That's about 4.9 seconds. So all of this happened in 0.4 of a second. Nothing you could ever see with your eye, right? But the Tscan will pick that up for you. Now, then something very interesting happened in the process of adjusting and using the data. Then I flipped up to the upper arch because the upper arch now had an implant under warning, an overload warning. And this is enclosure. This is now a new place. that's too high force. You see everything's getting better, right? But here's a new place. Now watch what happens when the person goes into the excursion. Watch this column go up before it dissipates. Watch carefully. See, it goes up and changes color, and then it goes down, and then the anterior guidance takes over, right? That's going to wedge that implant crown. You know, the patient's lower tooth is stuck in there, and it can't get out, and it creates intense pressure for all of maybe 1/100th of a second. But you can never know that with your eye, right? So that's, again, the beauty of the T-scan. It showed you which implant to fix. It showed you why it's a problem, both in closure and in excursion. Here's the closure at the end, right? You see the center of force comes down the middle. You see the low forces throughout. The natural teeth have a little bit more force. The implants have a little bit less force, all by design, right? All by outcome control. And then I think it goes left here, and you see the left excursion is anterior guided, but there's still drag, a little bit of drag. It's just about 0.6 of a second to get free. So these are important things to know, these timing values, which we teach you when the time comes. Now, that took from 10:28 in the morning to 11:25 in the afternoon. 11:25 in the morning, I'm sorry. So it took an hour to straighten that all out. So sometimes I'm lecturing and people say to me, they come up and say, I don't have an hour to adjust the bite. So I say back to them, do you have 8 hours? And they look at me funny. I said, well, the patient came back 8 times. Did you have 8 hours to fix it, right? And of course they say no, right? So by allowing yourself time to adjust the bite with the T-scan, you greatly improve the outcome. This is how he could have been sent home, right? Now, it doesn't mean he wouldn't come back and need some touching up, but certainly a lot less than this, right? That's the beauty of using the T-scan, because this is an illusion. Making the macro occlusion has nothing to do with the micro occlusion. The micro occlusion is where you succeed or fail with the patient. This is modern day dentistry. Any of these names you're seeing, these are dentists who've had me come to their office to teach them in office, to train them on how to use the T-scan, like we did with Richard. And I always take pictures, and we often have some very nice cases to show that represent exactly what's going on in the world of dentistry. So this is an all-on-6 case. The patient had this office, Dr. Alpetkin. He places the implants, he places the bone grafts, and he makes the prosthesis himself. And this was a milled zirconia, right? And you see the macro occlusion, and the smile looks great, right? Everything looks great. Yeah, until you put the T-scan in there, right? Because it was installed with carbon paper. And this is saying to you, the right side, everything hit at the same time, right? That's what it's saying to you, but it's not the truth, right? This is with a digital scan underneath, and you'll see what happens here. The right side definitely is not simultaneous. It's actually a 3-contact order, and then the left side is afterwards, right? Watch that again. And see the center of force, it's going to track around. It's going to go backwards, and then it's going to head towards the left side, right? It should just come like right to the middle, ideally. And so this is exactly what you're looking for. This is too early, this is too early, this is too early. It isn't that the purple ones are the ones you should adjust. You adjust everything that rises unevenly. So even though this one is green, that rises unevenly. The whole left side isn't together yet, and that's still rising, right? The pink ones you also want to adjust, but it isn't. One of the common errors that people make is that they think the pinks are the ones that matter, and what matters is the uneven rising, and that is not about color, right? It may rise to pink, but here you saw one rise and drop, right? Look at how this one rises and drops. Stuff you could never see with your eye, never know was possible to see, right? So after one adjustment, you see now the left side is too early. And then the right side is late, and the center of force totally shifted. Right? It actually went. We play the movie again. Let's see. If I leave it alone, there we go. You'll see it goes left, and then it comes back towards the middle. That's because the left side is too early and the right side is late. Right? So again, this is how you manage the occlusion. You use the digital scan, the mesial of the premolar, the distal fossa of the molar, the distal aspect of the upper left molar, the central fossa of the upper left molar. It's really nice with the digital scan. this is getting there. See, it's up, it's simultaneous, but no, this is a problem. This is a problem, right? And then at the end, watch the center of force. It comes right to the middle and it comes down the middle. And this area is probably a little too much. We probably should take some away from that, right? That took 6 adjustments to do, right? All in one visit. Here's the pre-op, very non-simultaneous, very right-sided, late left side, 3 implants under overload warning, very simultaneous, center of force comes to the middle and travels down the middle. All totally controlled by using the data, right? Let me see what else I have. Yeah, well, the macro occlusion. The macro occlusion is an illusion. Making the macro occlusion is important, but it doesn't guarantee you the micro occlusion. You need to be able to measure between the teeth for that. So let me just see. I have a good case. I'm going to skip ahead. Show you one case where we compare the two. This one. Oops, let me go back. This is a really good example of how the Tscan, what really happens when you improve the outcome with the Tscan. And then I'll finish up. I think this is the last case. So this is a classic today's dentistry, right? A whole bunch of implants with overdentures, ERAs, or locators, very popular, very rigid systems. You see the upper one with the locators, carbon paper marks. You know, what would you adjust here? Always ask yourself, when you look at the ink spots, what would you adjust? The question is not what, there's no right answer because there's no way to know. The ink can't tell you what to adjust, which is the real issue that we all face in occlusion. So, interesting about this case, this is the left side carbon paper. This is the right side carbon paper. Doesn't it look like the left side has more contact and more would have more force, right? There's a lot more ink here than there is here, but the right side is much more forceful, 66 to 33, right? And again, the idea of mapping the paper marks, knowing which ones to adjust, very important, right? Which ones to leave alone, which ones to treat. And this process is the same no matter what you're doing, right? So here's after one correction, I'll put this at the bottom. Yeah. And you see it didn't make that much of a difference. It's still very right-sided. It actually got worse. It went from 66 to 70, right? This patient also came back a whole bunch of times. After 2 adjustments, didn't improve it so much. Now, why am I showing you this? Because this is the reality of occlusal adjusting. It doesn't fix in one correction, whether you have a Tscan or not. It takes a series of corrections to be able to actually optimize. The secret is to know what to treat, right? So if you look at the movie Play, you have things that rise too fast. You have things that outpace other contacts here. So these 2, these 3, this one, right? That's how you know what to treat. Then this map shows you where to adjust. So here's the most distal palatal contact you can find, right? Here's near the mesial distal aspect of the tooth number 12, right? This is between 4 and 5. That's the paper marks that you'd be looking for. Here you'd be looking at the marginal ridge of 2 and the distal fossa of 2. After 4 adjustments, the center of force is trying to get to the middle, but you see the right side is still in the way. And so what I'm showing you is it's the fact that you need to do it a series of times to optimize is really important, right? So at the end, this is how it looked. Now there's still some uneven, there's still some uneven rising, right? And that's 4 adjustments, right? I went backwards. Here it is, as corrected. I apologize. You see, there's still some uneven rising, right? Now, what's the balance? It's 5% off now. The center of force comes straight to the middle. Now, this is the reason I want to show you this case, is if you play them together, they're set to play exactly at the same time. Watch what happens. How the postoperative one fills in much faster all around the arch than the preoperative one does, right? And you'll see this is slowed down to magnify that idea. You see the whole case is now together. There's almost equal balance. It's getting there, right? And here, this isn't even beginning to load, right? Now one tooth is going to load, and here the whole arch is loaded. So what we really did is speed up the timing of the outcome, right? We made everything meet much more simultaneous and achieved dramatically better balance, right? And that's the kind of control you have case after case with the Tscan. So to finish up, Tscan has many proven clinical applications. These are all the areas that we've published research in, right? And these are all areas that you all practice in: crown and bridge, dental implants, TMD, posture, braces or Invisalign, gum therapy, general occlusal diagnosis, veneers, and cosmetic dentistry, cold tooth sensitivity, right? That you actually can fix that in one visit. Treating appliances. You can still make appliances, but you can control the outcome much better. Think about it this way. If you have a bad right temporomandibular joint and you have a good left temporomandibular joint, and you want to help that right temporomandibular joint, and you're going to use a splint, what if you made the splint with 65% right, 35% left? You would never help that right temporomandibular joint, and you wouldn't know why it didn't respond, because paper marks don't show you 65% right, 35% left. There's just no way to quantify because you made the paper marks look the same. So there are all these daily applications for the Tscan, and it's a really powerful tool in every discipline. And from a practice management standpoint, which is a really important aspect that we showed you a lot of clinical things. The Tscan basically makes you money because it reduces fractures of components, but this is where it really saves you money in cutting down on those unwanted post-insertion occlusal adjustment visits. We have to see Mrs. Smith again, and for the 5th time, and she's stuck in the schedule somewhere to accommodate the fact that she's uncomfortable, and yet we have to see Mr. Jones in another room and make 3 crowns, and we really can't drill 3 teeth and deal with Mrs. Smith at the same time, and we run back and forth, and we don't necessarily get resolution, and she might need another visit, right? So these extra adjustment visits are a real loss leader in the dental office. The beauty of using the Tscan is you have improved outcomes because you have actionable, highly precise data to work from. Remember, the macro occlusion doesn't give you a good micro occlusion. And then you speed up treatment for patients. And I showed you a video of a patient before having an immediate response after Tscan adjusting. Well, here's another one. Let me move this out of the way. Different person.
So I kind of assumed that I would feel a difference in a few weeks or a few months or something as the muscles start to relax.
Yes.
But I didn't anticipate feeling something immediately. And I can already tell there's a significant difference when I'm biting down, a lot less pressure, and it's pretty miraculous that you can feel it immediately. It's definitely not at all what I was expecting.
Rapid patient physiologic adaptation. If you're interested in taking a course on the Tscan, the next one, which is really a general Tscan course, it's not specific to any one area. Some of these cases I showed will probably be shown, but it's really it's a full day course on how the Tscan applies to daily clinical practice. The next course is in May 20th in Denver at the Vivos Institute, which is a very nice teaching facility. It's a sleep center, but they teach a lot of occlusion, and they really are behind the Tscan. If you want to register, if it's something you want to look at, you can use the code. Let me see. Yeah, Introduction to Tscan is the name of the course. You would go to the Vivos Institute. This code will save you money, Tscan 23, if you're interested in registering. You can go to the Vivos Institute, just search for that, and you'll get to their website. And then one of the best ways to learn, as Dr. Stevenson can attest to, is having in-office training where you actually are guided in how to use the Tscan with patients. And typically 3 patients is a minimum. And that can be anything that you want to bring in. It can be a TMD patient. It can be an implant patient. It can be a patient that you might be having an occlusal problem getting comfortable with their new thing, their new implant overdenture or their crown and bridge case. And the staff is involved as well, because the staff if the staff is there, they see the patients respond and they realize this is a really significant advance. So if you're interested in something like this, Shane or Dr. Stevenson, they have my contact information that's down here, tmjdoc@ix.netcom.com. You can reach out to me, or through them, you can reach out to me, and we can talk about what one-on-one training really involves, which is the best way to learn. And it's a really important thing because this is the typical doctor learning experience who had the Tscan, someone who had it for a while.
I kind of thought I knew what I was doing with the Tscan, but I was really only using it at its most basic level to guide me a little bit on cases I was struggling with, or post insertion cases, bigger cases, but even then I was just using such a small piece of the equipment. Really didn't know what I was doing until I had you come in and do the in-office piece, and that's where the real learning took place. And then I finally started getting really good results.
Okay, so I'm happy to take any questions. And I really appreciate the opportunity to speak to you tonight. I want to thank Dr. Stevenson again for hosting, and for Shane for administrating. We really appreciate the opportunity to show you what the Tscan is capable of. And I certainly am grateful for the opportunity to work with Dr. Stevenson and his students. So this is my contact information if you're interested in reaching out to me. Also, this is Shane's email if you have questions about the product itself. And thank you very much. I'm going to unshare so I can be seen instead of seeing my slides. Let's see.
Thanks so much, Bob. Can you make me?
I made you the host already, so you can.
Oh, you already made me the host. Okay.
Yep.
There. Yes, I'm back. Okay.
Yes.
So we do have a Q&A interface at the bottom of your screen. If you have a question, it'll go there. But I wanted to just echo some of the things that you've already said. I've been a dentist for 36 years. I was a chairman of restorative dentistry at UCLA. I had that job for 17 years. I've got textbook chapters and papers and lectures all over the place, and I'm a member of all kinds of academies and what have you. I'm a Coyce graduate. I'm a Spear graduate. I'm a Dawson, I've done all of that stuff. And it left me with that last part that, is kind of the way I envisioned it. It was like, oh, this is the last little thing that'll just sort of, the cherry on top. It wasn't that at all. It was completely a complete, I was just knocked unconscious by how bad my results were when I started looking at Tscan. And I mean, I can show you the most meticulously refined, beautiful occlusions with all of the dots just looking gorgeous, textbook perfect, everything dialed in, and then horrendous numbers on Tscan on those cases, and then having to make the corrections and then getting the patients. I think a lot of my patients just don't tell me the truth. They're like, oh, Dr. Stevenson, he's taking care of me. So this must be the way it's supposed to feel. And then I'll make the adjustment. And they're like, oh, yeah, it can be better. Oh my gosh. So I don't know. I wish I'd done this so much earlier. And I know a lot of the I guess one of the barriers to this is that a lot of dentists, young dentists, are working for other people and they don't get the support, or they're working for corporate offices and they don't think they have the time. Or it's a chunk of change. We have kind of a little running joke in dentistry. Anything good in dentistry costs around at least $10,000. So Tscan's no different. But I think that if I had done this 25, 30 years ago when I was first aware of the technology, it would have changed my life. So one of the things a mentor can do for a mentee is share our mistakes and the things that we regret, and then you can kind of listen to that and decide whether that really applies to you. And this is one that was a huge regret, but I'm grateful now. I just need to have another 30 years of practice, and then I'll feel really balanced. Like I finally, I've really evolved as a clinician. So thanks again. We do have a couple of questions, and one of them comes from Kimia. And her name is Dr. Attar. She is a pros-trained person herself. She just opened up her private practice near Santa Barbara, California.
Oh, beautiful.
And she says, thank you for this great presentation. I have a question. I know the occlusal condition is different between patients, but in general, how long does this procedure take? Considering adjusting just one crown, for example, how long does it take to pull out the equipment, get all loaded up, and check it for one crown? I could give you my answer. But go ahead, Bob. Give her your answer.
For one crown, 10 minutes, maybe 15 minutes, no more than you would spend. It's really a great asset for a single crown because you target exactly what you need to adjust, so you're not randomly grinding, but no great time expense. The time expense comes in when the cases get bigger and that you really need the time then to be able to send the person home with a good outcome. And it isn't to say that everyone comes back and complains. You're actually right, Richard, that a lot of the patients, it's so interesting to go do all these trainings with doctors, and the patients they bring in, they're not all complaining about their bite. They're not saying my bite is off and I'm only hitting over here. But after they have it corrected, they say things like, yeah, I really only felt my left side and I didn't think it was a problem.
Right.
It didn't seem to bother me. The people that are bothered certainly come back, but then they see how different it feels, but also the doctor sees, wow, those 3 crowns I put in were really taking a lot of force, and the ones on the other side, they were really pretty good. I did pretty good, but these 3 I didn't do so good with. So the single unit is not a big time zap. It's really with the cases that get bigger. And I would say, having used it on almost everything that I installed, I would say a small procedure like a single crown or a 3 in a bridge might take me 15 minutes, no more to correct it. But large cases like these that I showed would take an hour to an hour and a half, and it might be done over 2 appointments. I might get it reasonably cleaned up so that it was good enough to send it out the door, and then have them come back a few days later and then optimize it. And that worked really well. Another way to save time with the big cases is to use that bisque try-in and case try-in, where it's already ready to, it's almost finished. And then you give it back to the technician with the corrected occlusal contours, and they give it back to you. And then the amount of correction at the delivery time is a lot less. Right? So
perfect. Yeah, I was
just a quick question thing too. One suggestion I would make is that if you're doing it with a single crown, I would always do a diagnostic scan before you touch that patient, because if you do a T-scan, you might find that they have other occlusal issues. And the moment you touch someone's tooth, you now own all their occlusal issues, unless, of course, you've done some diagnostic to show them that they have other stuff going on, which could also lead to more potential treatment being offered to that patient as well.
Yeah, in our practice, our workflow is that, I meet the patient and talk with them and get their consent to take traditional radiographs or, CBCT coming soon to our center. But right now I have to send them out for CBCT. But the other 2 things I do, other than a clinical exam, is I do a full scan with iTero or CEREC, you could, whatever, trios, and then I do Tscan. So now I've got some really great baseline data, and the patients are just bowled over. They cannot believe the level of, just the technology. And if you hear, one of the things that I kind of picked up on your presentation is, here we are in this digital workflow, and everyone's all excited about all the DICOM files and the surgical in the implant planning and printed technology and scanning and milling and all this stuff. And yet when it comes to delivery, we go back to this analog technology that is severely, short-sighted and unhelpful, really. So it's just strange, and I think when we talk about digital workflow in an intelligent way and at the highest level, you have to have this technology as part of your workflow. Otherwise, you're just fooling yourself. Yeah, make it low and let it grow. Sorry, that doesn't work. But that's what happens, I think, is that people just grind teeth too much, grind crowns too much, and then other teeth now are taking all the force and things super erupt, and just it goes on and on. It's a real mess out there. I think that this is also good technology used for direct restorations. We're talking about crowns and veneers and things like that, and implants, but a lot of people are doing direct composites. And they're having a lot of post-op sensitivity in their composites, or they're having the composites fail, or get stained margins and things like this, where I think we can mitigate a lot of those problems by implementing Tscan, certainly in cases that would be a little large enough to become involved in the occlusal scheme. I had one question here from Dr. Al-Khatib, and Dr. His question is, what is the mechanism that the Tscan treats hypersensitivity? And I think what he means is, like, how is it that,
Yes.
the Tscan, if you can just go over that again, that would be helpful.
Yes. Well, so the reason teeth get cold sensitive is the blood supply to the pulp, the blood supply of the tooth, of the nerve chamber is traumatized by the occlusion. And I don't know if you can see it, but if you've ever done anything like this, if you've ever repeatedly traumatized your skin, the skin turns white in the area you keep hitting it. So micro trauma causes vasoconstriction. So a tooth that's being pounded, either in closure or in excursions or both, the micro trauma, just like on my skin turning white, causes the blood to shrink up inside the tooth, and then the tooth no longer has insulation, and so the nerve feels the cold, right? And when you depressurize the tooth, whether it's excursive problems or it's closure, overload, instantaneously the blood supply comes back, and so the tooth now can resist most of the cold. And the studies that we've done and published are all 1 day. Patients are treated in 1 day. So they do the ice water swish, they have their bite corrected, and then they ice water swish again. And they do essentially what that young lady did. They give us a subjective number, right? And dramatic changes in statistical changes in before the ice water to after the bite adjustment. It's pretty amazing. But the mechanism is pulp. Anytime you have microtrauma, a blood vessel shrinks up. And so banging the teeth around causes the pulp to basically lose its blood supply. And then relieving the pressure allows the blood to come back in. And it happens within a matter of minutes.
That's very helpful. I don't have any current questions at this time. But I wanted to just follow up and let you know that our software is able to determine if you were here the whole time. And for those people who are here the whole time, the email list, your email will be sent to me from Shane, and I will provide you with 2 units of continuing education, ADA certified credit. You could use it for AGD, you can use it for your license, your state boards, whatever you need it for. And it'll be 2 hours in duration. If you happen to be watching this presentation as a recorded version, because it will be made available in this form, you'll need to submit a request to me at info@stevensondentalsolutions.com, and I will provide you with a quiz. You'll need to take a very straightforward quiz based off the presentation. After taking the quiz, then you get your CE credit. And that's so that we stay compliant with all of our continuing education guidelines. So I think that's basically it. I think we've answered all the questions. There was just a lot of information. I look at all the bars and all the pressure on the diagrams and on the sensor recording.
Yes.
And for me, yeah, and for me, it's just is so familiar, and I get it, and it didn't happen right away. It really takes some time to let it really get into your brain and make it something so that you can visualize it. What Robert does is help you shorten that learning curve when he comes into the office and spends time with you. And I think that was really an essential thing as part of my training, and I appreciate that again. But I think that's basically it for us tonight. And I want to thank once again Dr. Robert Kerstein for his presentation. It was excellent. And for Shane Varga for setting the whole web interface and for being our technical expert. You probably know more about occlusion than most people. There's one last question here. Can the sensor break if the forces are high enough? Great question. Go for it, guys.
Well, it's actually a very good question. So typically, the sensor will break from an extremely sharp or rough tooth surface or porcelain contour, or not a normal cusp, not a gold crown or a porcelain crown that has normal shapes, or a natural tooth that has normal shapes, but a jagged edge. It can cut the sensor. But typically, you can use one sensor for an entire correction, and because you can use one up to 24 crushes. And breakage is actually not a problem at all. Not to minimize that it can't break, because it can break, but it typically requires a real ragged edge, repeatedly striking the same place on the sensor. And that the sensor is designed to withstand repeated crushing and give off consistent data time and time again. So it works very well. But yes, it can cut, but it's not from the forces being too high. It's from the surface of the teeth being ragged or sharp or adjusted sharp. Like a lot of times you'll adjust porcelain and you can leave a little shelf or a ragged edge or a sharp point, and you'll end up with a cut in the sensor. And there's a way to actually remove that information from the data and continue to use the movie. You need to change the sensor, but a break in the sensor doesn't negate the movie. There's a way to actually correct for that.
And just make sure that if you do have perforation from a sharper cusp area, just locate that area and try and reduce or eliminate the sharpness, because otherwise you're going to keep going through more and more sensors if you don't correct the actual issue.
Yes. That's a very important point, actually, Shane. Thank you for making that. Right, you have to polish the area and round it out. And sometimes, even in the middle of a ceramic correction like zirconia, it's worthwhile polishing after a few cycles of adjusting, just to make sure you don't leave any ragged edges, and then continue on recording.
Very good. Well, thank you all for your excellent presentation. And gosh, it's been a lot of fun. And I guess let's do it again sometime. Okay, guys?
Sounds good.
All right. All right, everybody. Take care. Thanks for attending our seminar. Thanks again, Dr. Kerstein and Shane Varga.
All right. Bye.
Take care. Bye.
Thank you all. Have a
Bye.
good night.